guys, it's me, Professor D, and welcome back to my channel. On this video, I'm going to cover cardio, but more specifically, I'm going to cover questions that have to do with angina, okay? Angina and MI. I had somebody in the comment section ask me to cover this, so I tried to find as many questions as I could. They're kind of mixed, but I found a good number of questions that cover this topic. Now, guys, just so you know, when I go over questions with you guys, I don't just go over any questions I find. I actually pick out the questions that have been seen very, very often on NCLEX, on HESI, on ATI. Okay, so these are the same concepts that you're going to see on your midterm, on your final, on your exam if you're covering those topics. Okay, so every single question that I give you, those are concepts that have been seen over and over and over again, and I know it's important for you to know. If you haven't done so already, of course, as always, be sure to press that like, comment, subscribe button below. All right, first question. Which of the following actions is the first priority of care for a client exhibiting signs and symptoms of coronary artery disease? 1, decrease anxiety. 2, enhance myocardial oxygenation. 3, administer sublingual nitroglycerin. 4, educate the client about his symptoms. And I'll give you a moment to think of your answer. Okay, guys, so the correct answer is 2. The first thing you want to do is enhance their myocardial oxygenation. So let's go back to the question where it says, which of the following actions is the first priority of care when a client's exhibiting signs and symptoms of coronary artery disease? So you have to remember, what are the coronary arteries responsible for? The coronary arteries are responsible for bringing blood, oxygen, vitamins, nutrients to the heart. So we know there's veins and there's arteries. Veins brings unoxygenated blood back to the heart, and oxygen, and arteries bring oxygenated blood to the whole body, right? So the heart is responsible for supplying oxygenated blood to all of your organs, all of your tissues, all of your cells, everything. But guess what? Your heart itself is a muscle. It's tissue, right? And the heart itself needs its own supply of blood, oxygen, vitamins, nutrients. So the coronary arteries are the arteries that specifically bring that blood, that oxygen, vitamin, nutrients to the heart muscle itself. So if the coronary arteries are in trouble, guess what the heart's not receiving? Oxygen, vitamins, nutrients. Is not receiving all the good stuff that heart needs to survive. So the very first thing that you want to do is increase the oxygen. Increase that supply. So that's why number 2 is correct. Look at our other choices. Decreasing their anxiety, that's wonderful, but you can do that later. Your first priority is getting that oxygen to the heart. Remember that oxygen is being carried in hemoglobin. That hemoglobin is being carried in the RBCs. The RBCs is what? In the blood, okay? So yes, you want to decrease their oxygen, you want to decrease their anxiety, but the first thing you want to do is increase their oxygen. Choice 3, give them sublingual nitroglycerin. Well, sublingual nitroglycerin is wonderful because it causes vasodilation. It increases blood flow. That's wonderful. But the first thing you want to do is increase oxygenation. Okay? So you're going to do that later. Number 4, same thing, educate the client about their symptoms. Teaching, all of that can come later. But the very first thing you want to do is increase, and specifically choice 2 says enhance what kind of oxygenation? Myocardial. Because remember, if patient has coronary artery disease, it's the heart's in trouble, okay? When you say that word myo means muscle layer, okay? So myocardial, the muscle of the heart, is what's in trouble, and that's what you want to increase the oxygenation of, okay? So I know some of you guys would want to be tricked and you'd want to choose sublingual nitroglycerin. That's great. It causes vasodilation, and that's wonderful for angina, right? But if you're stuck between that nitroglycerin and increasing the myocardial oxygenation, it's going to be increasing the myocardial oxygenation every single day of the week, okay? Next question. What is the primary reason for administering morphine to a client with an MI? 1, to sedate the client. 2, to decrease the client's pain. 3, to decrease the client's anxiety. Or 4, to decrease oxygen demand on the heart. I'll give you a moment to think of the answer, even though I already gave you the answer in the first question. I'll give you a second. The correct answer is 4. We want to decrease the oxygen demand on the heart. So guys, if a patient has this MI, the heart's in trouble. Okay? Remember, I told you in the first question, I told you the heart is what's responsible for supplying oxygenated blood from the tip of your head to your brain, to your scalp, to your toes. Okay? The heart's responsible. So if the heart's in trouble, you want to rest the heart. So when you decrease the demand of oxygen, you're helping the heart do what? Rest. Okay? So that's why number 4 is the answer. You want to decrease the demand of the heart. Morphine is wonderful. You know, it has other effects that we like, such as number 1, sedation. That's wonderful, but that's not the goal. 2, yes, morphine decreases the client's pain, and that's wonderful, but that's not our primary goal. 3, decreasing patient's anxiety. Yes, morphine will decrease the patient's anxiety because as their pain decreases, their anxiety is going to go down. Yes, that's wonderful, but that's not our goal of giving morphine when it comes to myocardial infarction. Our goal in giving morphine is to decrease the demand that's placed on the heart for oxygen. Okay, so 4 is the correct answer. Next question. What is the first intervention for a client experiencing a myocardial infarction? 1, administer morphine. 2, administer oxygen. 3, administer sublingual nitroglycerin. 4, obtain an ECG. And you guys should know this answer. I just covered this on the first question. You notice how you guys are getting the same concepts, but they're being asked in a different way? I'll give you a second to think of your answer. And the correct answer is number 2. Once again, we want to increase their oxygenation because the problem is the reason they're having this pain is because that heart is screaming out saying, help, help, I need oxygen. That's where that pain's coming from. So you want to increase the oxygen in the patient and decrease the demand for it in the patient. Okay. So the first thing you want to do is give that patient oxygen. Everything else comes afterwards. So giving morphine, wonderful, after we get them oxygen. Nitroglycerin, wonderful, after we give them oxygen. And ECG, that's not so much an intervention, that's actually like a diagnostic test. And that helps us to look to see what's going on with the heart, okay? So doing an ECG, yes, that intervention, that's wonderful. After we give that patient oxygen, then we can look to see what's going on, okay? The first thing you want to do is give them oxygen, okay? When it comes to myocardial infarctions, I did this in another video. Don't forget, I taught you MONA, M-O-N-A. You want to make sure they get morphine. You want to make sure they get oxygen. You want to make sure they, what's my N stand for? M-O-N. You want to give them nitroglycerin and A, aspirin, all right? You want to make sure the patient doesn't throw out any clots. Which of the following conditions is associated with a predictable level of pain that occurs as a result of physical or emotional stress? 1, anxiety. 2, stable angina. 3, unstable angina. Or 4, variant angina. And I'll give you a moment to think of your answer. And so the correct answer is 2, stable angina. So Let me explain to you guys what stable angina is, and then we'll go over the other choices. So with stable angina, that's the chest pain that the patient gets, but they know they're going to get it. It's predictable. So the patient knows every time I have sex with my wife, I get this chest pain. So if I'm going to get down with my wife tonight, I'm going to go ahead and have my nitroglycerin ready. Or I know every time I garden, I get the chest pain. Or I know every time I go for a walk and as soon as I pass 1 mile, I get the chest pain. Okay, so with stable angina, it's predictable. We know when it's going to come on. And it's not as severe as unstable angina. So, you know, the pain is mild. Okay, it's not severe. And the third thing, what's the third thing you guys need to know about unstable angina? Oh, the third thing is that it's short lasting. And what do I mean by that? The minute you stop doing what it is that caused angina in the first place, it goes away, right? So with stable angina, we know what's going to bring it on. It's mild, it's not severe, and it's not long lasting, okay? So that's stable angina. So that's the correct answer because we know that it's something predictable. It's a predictable level of pain and something such as physical exercise or stress. Stress such as what? You know, every Friday you have a weekly meeting, and as soon as your boss starts yelling at you, your chest hurts. That's predictable, right? So let's look at our other choices. Number 1, anxiety. Anxiety, does it cause chest pain? It should not, okay? 2, well, that's the answer. Then you have 3, unstable angina. So let me talk. Oh, I told you what the stable angina was. Let me explain the difference between that and unstable angina. Unstable angina is the opposite. With unstable angina, you have no idea what will trigger it, right? So remember, in stable, you know if you garden or if you run and jog or if you have sex, you know it'll come on. But with unstable angina, you don't know what brings it on. Second thing with unstable angina, that pain is severe, okay? With unstable angina, that's the one that's linked to the heart attack, to the myocardial infarction, okay? It is severe and it lasts a long time. Remember how I told you with unstable angina, as soon as you rest, that pain goes, with stable angina, as soon as you rest, the pain goes away? Not with unstable. With unstable, not only is it unpredictable, not only is that pain severe, it's long lasting. Matter of fact, let me take a step further. It's long lasting, and the more time that goes by, the worse that pain is. That's how patients know the difference of angina or if they're having a real heart attack. Because if their chest is hurting and then they rest, and then, oh, it went away, most likely it's not myocardial infarction. But that patient's having chest pain and then they rest and that chest pain is still there. And matter of fact, it's getting worse. Possibly it could be a myocardial infarction, okay? So number 3 is incorrect. And then choice number 4, variant angina. So variant angina, just like the word says variant, I want you to think of varies. So when I say varies, usually the patient will get it either really early in the morning or they'll get it really late at night. So it's a chest pain that the patient gets. Now this type of chest pain, like unstable, it's severe. It's severe. It's very painful, but it's predictable. And what I mean by that is they'll get that type of chest pain in the morning when they wake up, or they'll get it in the evening. But it's predictable where they'll get that type of chest pain around the same time each day, okay? So the correct answer is number 2, and I explained why. Next question, which of the following types of angina is most closely related to an impending myocardial infarction? And I just gave you guys the answer. So here are your choices. 1, angina decubitus. 2, chronic stable angina. 3, nocturnal angina. 4, unstable angina. And I'm not even going to give you guys a moment because I just gave you guys the answer. The correct answer is unstable angina. That's the one that's most closely linked to myocardial infarction because it's severe. You never know when it's going to come on because it's not predictable, and it's long lasting and progressive. And when I say progressive, that means as time goes by, it gets worse if the patient doesn't get any help. Next question, which of the following conditions is the predominant cause of angina? 1, increased preload. 2, decreased afterload. 3, coronary artery spasm. Or 4, inadequate oxygen supply to the myocardium. And I'll give you a moment to think of your answer. And you guys all should have gotten this right because I also explained this with the very first question. The correct answer is 1, not having enough oxygen going to the muscle of the heart. Did I say answer is 1 or 4? 4, I'm sorry. 4, inadequate oxygen supply to the myocardium. Let's go over our other choices. So 1 said increased preload. With increased preload, you tend to see that in patients that have a right-sided heart failure, okay? 2, decreased afterload. Decreased afterload, that's it's caused by decreased cardiac output. And so what happens is you're going to see less oxygen, vitamins, nutrients, less blood supply going to the tissues. 3, coronary artery spasm. You usually see that in a variant angina. And then, of course, our correct answer, 4, inadequate oxygen supply to the myocardium. That is the #1 reason why patients will have chest pain. There's not enough blood, which carries the oxygen, vitamins, nutrients. There's not enough of that going to the heart muscle itself. So the heart starts screaming, help, help, help. And that scream for help is that chest pain that the patient feels, which is the angina. Which of the following tests is used most often to diagnose angina? I think I gave you guys this answer already as well. 1, chest pain. 2, an echocardiogram. 3, a cardiac cath. 4, 12-lead electrocardiogram. That's the ECG. And the correct answer is 4, your ECG. So basically the ECG gives you a picture of the heart and how well it's doing. It shows if the patient's having any ischemia, okay? What you expect to see in the situation, if the patient's having angina, you're expecting to see an inverted T wave. And if they're having variant angina, you expect to see an ST elevation. Hence, STEMI, STEMI. Yeah. Okay. Next question. Which of the following interventions should be the first priority when treating a client experiencing chest pain while walking? 1, sit the client down. 2, get the client back to bed. 3, obtain ECG. 4, administer sublingual nitroglycerin. And I'll give you a moment. And guys, I think this is about the 3rd question we're getting that it's the same concept. They're just asking it in a different way. The correct answer is 1, sit them down. Why sit them down? What are we doing when we're sitting the client down? We're decreasing their oxygen demand. Remember, I told you if a client's having chest pain, they're having an MI, we want to do 2 things. Increase their oxygen and decrease the demand for oxygen. Once you make that client rest, you're decreasing the demand for oxygen. And that's your answer. Have them sit down. You want to decrease the demand. Look at our other choices. 2, get the client back to bed. We can do that later. But if that client's walking right where they are, have them sit down. Why are we going to walk them back to bed? That whole time they're walking back to bed, we're increasing the demand that we don't want. We're going to have them rest where they are. 3, obtain an ECG. Wonderful idea, but that can wait. For right now, we need to decrease the oxygen demand. 4, administer sublingual nitroglycerin. Wonderful, but what's the point of giving them sublingual nitroglycerin if that patient's still doing something to increase the demand? No, the first thing we want to do is decrease the demand while increasing the oxygen. So that's why #1 is the correct answer. Next question. Which of the following positions would best aid breathing for a client with acute pulmonary edema? 1, lying flat in bed. 2, left side lying. 3, in high Fowler's position. 4, in semi-Fowler's position. Now, if you're one of my students, you've had me in the classroom, and you already know what this answer is because I know you remember what I did in class, right? To give you a visual. So the correct answer is 3. You want that patient in high Fowler's position. Why? That diaphragm, the diaphragm's lower. I just want you to see my hands though. That diaphragm, which is sitting pushing up against your lungs, when you have them in high Fowler's position, it helps lower the diaphragm. Gravity helps, right? And it helps the lungs do what? Expand. So it helps that patient breathe better. The lower you put that patient, the harder it's going to be for them to breathe, because now they're fighting against gravity just for their lungs to expand. And then, of course, you have the diaphragm that's pushing up on the lungs, making it even worse. The nurse coming on duty receives report from the nurse going off duty. Which of the following clients should the on-duty nurse assess first? Now, guys, remember what I taught you in my priorities video. Don't forget. So which patient are you going to see first? 1, the 58-year-old client who was admitted 2 days ago with heart failure, blood pressure 126/76, respiratory rate of 21 breaths. 2, 88-year-old with end-stage right-sided heart failure, blood pressure 78/50, and the DNR order. 3, 62-year-old client admitted 1 day ago with thrombophlebitis, receiving IV heparin. 4, 76-year-old client admitted 1 hour ago with new onset atrial fibrillation and receiving cardizem. So I hope you guys all chose 4. And guys, they gave you such a beautiful hint in the choice. It said a 76-year-old that was admitted 1 hour ago. So this is a fresh client. Remember, any clients who are fresh, who are new, require a lot of in-depth assessment, right? So that's your first hint. They just came in 1 hour ago with new onset. Remember, I taught you any patient that has a new diagnosis of anything, the RN has to, not only does the RN has to see that patient, you're going to be going to them because you want to make sure they're stable. Okay, so they gave us 2 hints, and then the patient's on IV cardizem. That was our 3rd hint. That's who we're going to run to first, because that's the most unstable patient. Whenever you have a question asking you, who do you see first? Really what they're asking you is who is most unstable, who is a priority at this time. So that's who you're going to see first. This patient's new. They just came in an hour ago. They have a new diagnosis, and they're on a very they're on a med that can potentially be caustic. Okay, those 3. So you're going to see that client first. So the correct answer is number 4. Let me tell you who you're going to see second. Second is going to be number 3. The 62-year-old that came in a day ago. So it's not as bad as an hour ago, but it's still bad. They came in a day ago. And they're getting IV heparin. IV heparin, you better be watching that patient very closely, and they better be on a pump, right? Third, you're going to see number 1, the 58-year-old that came in 2 days ago. Not as bad as the 1 day ago, so that's why we're seeing them third. They came in 2 days ago, blood pressure 126/76, okay, but respirations 21. Not that bad. Most books 12 to 20. That's why they're third on the list. And last is going to be your 88-year-old that has end-stage right-sided heart failure, blood pressure 78/50. That's horrible, but they have a DNR. That patient's dying. They know they're dying, and they signed a DNR. They don't want to be resuscitated. Does that mean we're not going to check on that patient? Does that mean we're not going to assess that patient? Absolutely not. But when we're making our list of priorities, they're not up there, okay? So I want you guys to kind of see what's happening here. You're going to see the most unstable patient, any patients that have a new diagnosis, any patient that are brand new to you that you haven't been able to assess yet, any patient that are on caustic meds, any patient that are on very dangerous meds that have to be on a pump. All of those are priority patients, and those are who you're going to be running to first. A nurse is preparing to ambulate a client on the 3rd day after cardiac surgery. The nurse would plan to do which of the following to enable the client to best tolerate ambulation? 1, encourage the client to cough and deep breathe. 2, premedicate the client with an analgesic. 3, provide the client with a walker. 4, remove telemetry equipment because it weighs down the hospital gown. And I'll give you a moment to think of your answer. Okay, guys, so the correct answer is 2, premedicate the client with an analgesic. Why? An analgesic does what? Decrease pain. Patient's pains decrease. Guess what that does? Also decreases anxiety. What does that also do? Decrease oxygen demand. How many times do I have to tell you this? When it comes to angina, when it comes to myocardial infarction, we want to increase the oxygen while we're decreasing the demand for oxygen. So we're about to walk this patient. Don't you think walking is going to increase that patient's oxygen demand? Of course, because if that patient's moving, right, those muscles, those ligaments, those cells are going to need oxygen. They're going to need to be perfused. They're going to need to be fed. How are they fed? With blood. Who's responsible for pumping the blood? The heart. So just the fact that they're moving, the heart is going to have to work harder. So what are you going to do to help out the heart? You're going to decrease the demand on the heart by what? Giving them an analgesic. Remember our MONA, M-O-N-A? M is morphine. That's our analgesic. Even though, yes, morphine is analgesic and we give it for pain, when it comes to the heart, the reason that we give it to the patient, predominantly, the number one reason is to decrease the demand. All of the other good stuff that comes with morphine, that comes with analgesics, those are extras. Those are icing on the cake. But the reason we give it is to decrease the demand. Okay? Let's look at our other choices. 1, encourage the client to cough and deep breathe. That's not going to help the patient tolerate walking. Having the client cough, deep breathe, that helps with them not getting an infection such as pneumonia, right? That's wonderful for that, but that does not help that patient tolerate walking. So number 1 is a beautiful answer for another question. 3, provide the client with a walker. The walker may help the client ambulate better, but it will not help the client tolerate the ambulation. Okay? Choice 4, remove the telemetry equipment because it weighs down the hospital gown. Are you crazy? You better not. You mean to tell me you have a client that just had an MI? They just had surgery. This is your first time walking them and you're going to disconnect them from, you better not. You better know what that patient's doing while they're ambulating. So we're going to get rid of number 4. So you know for sure the correct answer is number 2. You want to premedicate them. Why? We want to decrease the demand on the heart while we do what? Increase the oxygen supply. A home care nurse is making a routine visit to a client receiving digoxin in the treatment of heart failure. The nurse would particularly assess the client for 1, thrombocytopenia and weight gain. 2, anorexia, nausea, and visual disturbances. 3, diarrhea and hypotension. 4, fatigue and muscle twitching. Okay, so there are a couple things you guys absolutely have to know about digoxin, okay? The correct answer is 2, anorexia, nausea, and visual disturbances. So there are a couple things you have to know about digoxin. Digoxin, whenever you give digoxin, before you give it, you have to take the patient's apical pulse for 1 full minute. Not radial, apical, and you're taking it for 60 seconds, 1 full minute, okay? We love digoxin because digoxin increases the contractility of the heart. So what does it do? If the heart was pumping like this, because especially if you have CHF, you have all of this fluid you can't pump out, right? So the heart was pumping like this. You give them digoxin, and digoxin increases the contractility of the heart. All of a sudden, the heart's pumping like this. It's really getting all that blood out, right? It's really getting all that blood, oxygen, vitamins, nutrients to every single part of your body. So we love digoxin because digoxin does what? Increase the contractility of the heart. But at the same time, even though it increases the contractility of the heart, it slows down the heart rate. Why is that important to us? If we take that patient's heart rate and their heart rate's 60, are you going to give that digoxin? You better not. Okay? Because we know that heart rate is 60 to 100. So yes, we love digoxin. Yes, we wanted to increase the contractility of the heart, but we have to be careful. We might throw that patient into dysrhythmia. Okay? That's why we're taking the apical pulse for a full minute and making sure that that heart rate is within the parameters, because if it's not, you're going to do what? Hold the medication. Don't give it, and then you have to call the physician, okay? So with digoxin, you have to know that it increases contractility. You have to know it decreases the rate. You have to know your range. Digoxin has a narrow therapeutic range. And you know, I've talked to you guys about this before. There's certain drugs that have narrow therapeutic ranges, which means that the range that's therapeutic to a patient is this much. And once you step out of it, it can have deadly consequences. And digoxin is one of them, okay? So you have to know your range for digoxin depending on the textbook that you use. Usually it's about 0.8 to 2. Some books say 0.5 to 2. So just look at your textbook. For testing purposes, it'll be way out of range. So either you know it or you don't. All right. It's not going to be a couple points. It'll be way out of range. So 0.5, 0.8 to 2, depending on your book. But once you hit about 2.4, you're toxic. Okay. 2.4 higher, you're at the toxic range. So you have to know those three things. I'm missing one. Increased contractility of heart, decreased heart rate. You need to know the level. Oh, and remember how I just told you, you hit 2.4 or higher, you're toxic. You need to know those signs and symptoms of toxicity. And that's what they're talking about here. If a patient's getting digoxin, what is the nurse going to be looking out for? Choice number 2, anorexia, nausea, visual disturbances. You know, along with the something else that patients tend to complain are stomachs, tummy aches. Okay, so them having abdominal pain also. All of those are signs and symptoms of dig toxicity that the nurse should be looking out for. Okay, this is our last question. I've surpassed my 30 minutes, but we'll do this last question. A client with angina complains that the angina pain is prolonged and severe and occurs at the same time each day, most often in the morning. On further assessment, the nurse notes that the pain occurs in the absence of precipitating factors. This type of anginal pain is best described as 1, unstable angina, 2, 1, stable angina, 2, unstable angina, 3, variant angina, or 4, non-anginal pain. And I'll give you guys a moment because they gave you all the clues that you needed to know to eliminate all the choices and leave you with one. So I'll give you a second to look at the question choices. So guys, the correct answer is 3, and that's the only choice you could have had, variant angina, sometimes known as Prince-Mall's angina. You see Prince-Mall variant, they're talking about the same thing, okay? That's the only one it could have been, guys. Look at first choice, number 1, stable angina. Well, remember, I told you with stable angina, it's predictable, but it's short, and it's not severe. Well, in the question, yes, it's predictable, it happens in the morning, but it also says that's severe. So it can't be number 1. You should have been able to rule that out. Then you have choice number 2, unstable angina. Well, you guys know that unstable angina is unpredictable and severe. But in the question, even though it was severe, it was also predictable. So we had to get rid of number 2. That's not the definition of unstable angina. So now we got rid of 1 and 2. That leaves us with 3 and 4. Let's look at choice 4. Non-anginal pain. Non-anginal pain is chest pain that the patient has that has nothing to do with the heart. Okay? And here in the question, they let us know that the patient's having chest pain, anginal complaints. They're having chest pain, occurs the same time each day, is severe. That is your definition for what? Your Prince-Malls, your variant angina. So the correct answer is number 3. Guys, I hope you found this video helpful on angina and kind of understanding the difference in the different types of angina and the nursing interventions, what you do for them. Please, guys, do not forget my review coming up is August 29th through 30th. If you want to register for it, just go on my website, www.nexusnursinginstitute.com. If you have any friends that are in a nursing program just graduated that want to review, please pass on this information. And if you haven't done so already, please don't forget to like, comment, and subscribe below. I'll see you next time.